This meeting is being recorded. This is the OHDSI Phenotype Development Evaluation Workgroup. We meet every 2 weeks on the second Friday and the fourth Friday of every month. So today, I see several people on the call. Is there anybody who's new to the workgroup that would like to introduce themselves? Okay, so we have two main agenda items that we want to cover today. One is a presentation or discussion led by Dr. Boyce and his team about an idea that they're proposing. The idea is to share with us some of the work that they have done with the OMOP Common Data Model in terms of the phenotyping. So we're going to talk about it, going to learn from them, and then we will use the rest of the time to talk about the ongoing discussion that we have had for the OHDSI Symposium workshop. Dr. Boyce, do you have a slides, or do you want to present in a certain way?
Oh, thank you. Yeah.
And please go ahead and introduce yourself. We are very informal in this group.
Okay, thank you. Well, hello, everybody. I'm Rich Boyce. I'm at the University of Pittsburgh in the Department of Biomedical Informatics, and I've been around the OHDSI community for a while, mostly working on what used to be the pharmacovigilance evidence work group, and then now I'm working a lot with the Atlas web API team. But I intersect sometimes with other work groups. And today, Dr. Shaotong Li, who's working on her PhD in School of Pharmacy here at the University of Pittsburgh, and who's done a tremendous amount of good work with us on potentially inappropriate medication analyses. She's going to talk about, just introduce the topic very briefly, talk about some stuff that we've done. She has some slides. Shaotong, would you like to go ahead and present the slides and walk us through it real quick? Thank you.
Yeah. Can you see the screen?
Mm-hmm.
Yeah. And good morning, everyone. I'm Shaotong Li. I was trained as a pharmacist, and now I am a PhD candidate in the School of Pharmacy from University of Pittsburgh. Today, I have the pleasure of discussing a critical issue, potentially inappropriate medications, and our computational approach to identifying them using the OMOP Common Data Model. We have previously shared our preliminary work at the OHDSI Symposium in 2022. And let's begin with a fundamental question. What exactly are potentially inappropriate medications, or PIMs? In a sense, PIMs are drugs where the risks outweigh the clinical benefits, particularly when safer, more effective alternatives exist. The impact of PIMs is substantial and quantifiable. They increase the odds of adverse drug events by 26% and the odds of unplanned hospitalization by 23 to 64%. And in the United States, for adults 65 and older, PIMs contribute to an increased annual healthcare expenditure of more than $400 per capita. So clearly, addressing PIM is a critical healthcare priority. And we can see that older adults present unique challenges due to physiological changes that alter drug pharmacodynamics and pharmacokinetics. These age-related changes necessitate specialized prescribing consideration to mitigate adverse drug reaction and ensure optimized effectiveness. And consider this. The National Center of Health Statistics reported that over 88% of older Americans use at least one prescription medication monthly, with 66% use 3 or more. So as we transition into a super-aged society, with 20% of our population soon to be 65 or older, the importance of appropriate prescribing cannot be overstated. So that brings the importance of the criteria for defining PIMs. The Boyce criteria was originally conceived in 1991 by Dr. Mark Boyce, a respected geriatrician, to catalog medications that often cause side effects in older patients. In 2011, the American Geriatric Society, AGS, became the criteria steward. Now, under their guidance, the Beer criteria provide a detailed list of potentially inappropriate medications. These are drugs that, in most cases, should be avoided by older adults, except for those receiving hospice or end-of-life care. The AGS Beer criteria plays a pivotal role in geriatric care. They aim to guide medication selection, educate healthcare providers and patients, reduce adverse events, and set benchmark for evaluating care quality. It was developed by a 12-member expert panel of physicians, pharmacists, and nurses specializing in geriatric care. The process adhered to the GRADE guideline, ensuring a systematic evidence review for each PIM. This process includes extensive internal review and public comments from over 40 organizations, ensuring broad and thorough vetting. It is really a useful guideline, and let's show an example from the 2019 AGS Beers criteria. Consider first-generation antihistamine, totally not recommended for older adults because of their strong anticholinergic effects and slow clearance as we age. These drugs can lead to confusion, dry mouth, and constipation. However, an exception like diphenhydramine might be appropriate for severe allergy reactions in older adults. So, to effectively implement the Beers criteria, our team utilized the OHDSI platform with its Common Data Model, comprising both pharmacy students and clinical pharmacists. Our team crafted logics to define exposure to PIMs while establishing code sets with clinical judgment. By using the Xenome code for disease and using Rx norms for medication, we tailored our cohort definition. This methodological approach helped us to identify 37 distinct classes of medications that are potentially inappropriate for older population. And this is how we define with the PIMs with Common Data Model. Dr. Boyce, would you want to show our definition on Atlas?
Yeah, if I can share my screen for a second here. It will only take a second. So if you can see our screen here, this is a listing of, as was mentioned just a minute ago, the 37 or so definitions that we have. So she was showing first generation antihistamines on the board there. Let's see if this will load okay. Of course, if demos, we'll see what happens. But basically, the thing that's important here is that with pharmacist review, we went in and we defined specifically the situations where the antihistamines could be appropriate versus when they're inappropriate, and then created the logical definitions using Atlas. So this then becomes, a computable, potentially inappropriate medication. And then we went further after creating all these things, and we did further analyses using, for example, the incident rate tool within Atlas. And Shaotong can talk about some of the results that we had from both that analysis and things that followed. But that gives you a sense that for all of these Beers definitions, there's a logical definition that was created, and we have the ability to export those out from the Atlas tool.
Got it. Asa, you have your hand raised?
Yeah, can I quickly ask you a question? And we can wait until the end if you prefer that.
However.
So this is looking good. I have a question about, so the logic, just high level, the logic that is implemented is purely to implement the criteria or the scenarios that are listed based on the clinical and pharmaceutical decisions, correct? Was there anything in that modeling in Atlas done purely to do something specific for how the data is ETL'd or specific to your situation that won't apply in other situation. I see like a drug prescription type or something that is listed in your logic, where there are things that are, you know, pure a work around things that are in the ETL or things around how Atlas implemented, or is it only purely implementing the clinical rubric?
That's great. Yeah, so we did our best to follow the standard concepts, the standardized concepts for the types of prescriptions and for the medications themselves and the logic. So in principle, we think that these could be applied generally, but that hasn't been tested yet. But one of our goals was to not be overly specific to our specific data set and our transformation. Thank you.
Great. And follow-up question to that, the logic, was there, does the Beers criteria have a logic specified that was then interpreted and translated into Atlas, or was it a Beers criteria was just a clinical idea that was then interpreted and a logic was created by your group?
I will have Shaotong add on to what I say, but my perspective on that is there is in the tables in the published Beers criteria, there's sort of inclusion-exclusion criteria to qualify as a potentially inappropriate versus an appropriate use of a specific medication. So we think of that as logic in the sense of its presentation in the document, and then we translated that into Atlas. Shaotong, would you agree with that?
Yes, and we are mainly implementing these logics reported by Beers in our data by using some computational approach. It means that it enables us to implement these logics with data. Because in the manuscript they reported, for example, the list of 10 first-generation antihistamines are not appropriate for older adults, and we try to identify these medications in the older adults from their prescribing and use the RX norm codes to identify these medications in the data.
Got it. Thank you.
Thanks for the good question. And now let's move to the result. And this is the result. Analyzing electronic health records from the University of Pittsburgh Medical Center spanning from 2015 to 2018, our study identified more than 300,000 patients who met our eligibility criteria. Patients who had at least one outpatient prescription during the study follow-up time. Among them, we observed an incidence rate of 193.5 cases per 1,000 person year. The medication classes with the highest incidence of PIMs are short or intermediate-acting benzodiazepines, first-generation antihistamines, and skeletal muscle relaxants.
This is the incidence, sorry, this is the incidence of use of the drug, correct?
Yeah.
And what was
this is the incidence of prescribing the drug, because when using electronic health records or claims data, it is almost impossible to exactly identify whether this patient has consumed this medication. But the prescribing already reflects what medications are prescribed for these patients. In most cases, patients will follow these instructions from physicians to take these medications. We cannot tell which patient takes or not, but it's already inappropriate when physicians prescribed them.
So Li, those are each each group on your y-axis is one of the groups that are listed in the guidelines, correct? And those are the incidents based on the definitions that you guys implemented in Atlas, and these are the incidents in your data sources, correct?
Yes. The medications, either a specific medication or a class of medication in the y-axis, are those reported in the BS criteria and later implemented. We didn't show the whole 37 because that's too crowded.
Yeah.
But we have the whole list.
And
Right.
then one more question, Gautam. And then you're saying here incidents. So you're classifying those as new like it's a first and only prescription or like uptake of those medications based on the definition. So you're only quantifying one per person, which of course it could be higher than that because the same situation might occur for the person over and over. But here for simplicity, we're just looking at the incidence, meaning that you're counting one event per person and it's the first that happens in the database, correct?
Yes.
And even that you see considerable occurrence, and even though you're only really counting it once.
Yes, even we only counted it once among those patients who did not have prescription of PIMs at first. That's how we calculated incidence. We also calculated prevalence, and to my memory, the 1 year prevalence of PIM is about 30% to 40% in our data. So that's a really high incidence and prevalence.
Wow.
So quick question. This is not just age related. For each of these different categories on the y-axis, there may be different reasons why it was inappropriate for somebody to get antidepressants, for instance.
Mainly they are for older adults, inappropriate for older adults, because those medications, they are still on the market for some reason. Just in older adults, there is outweigh the benefit.
Okay, so this is basically 65 and older.
Yes.
Okay, people that
Yeah.
We will add that.
I would comment that the part of the motivation for us doing this work here at the University of Pittsburgh is we have access to Pennsylvania state data for a supplement program that involves lower income older adults. And so part of what we were working on was looking at, does the managed prescription benefit plan have any impact on exposure to potentially inappropriate medications? And then later on, is there any difference in outcomes? And so this is showing, work that was done with both the people in that program and people who were from a pool of potentially matched controls, that everybody was older than 65. And then there's nuance, as Shaotong was referring earlier. It isn't just you're older and you're getting the med. There's a lot of nuance as you go through the Beers criteria as to when it's appropriate versus not. Oh, thank you.
Adam, you have your hand raised.
Yes, I have a question in regards to comorbidities. Have you looked at stratifying this result based on comorbidities and risk factors? Thank you.
Based on comorbidities, you mean, did we identify the incidence in each group with different comorbidities, or?
Yes.
Sorry.
Yes, exactly. Yeah.
We did not identify these PIMs in different comorbidities group, but is there a specific reason that you want to explore that?
I was like thinking about pressure ulcer or pressure injury.
Pressure injury?
Yeah, like because sometimes it might happen because you are looking at older adults. So I was doing a project currently in pressure injury, and I was wondering if there is any associations between these PMIs and pressure injury or any other comorbidities that are prone to elderly.
Oh, yes, and So far, we haven't done that, but we have a later plan to investigate the implements of PACE on the PIMs and adherence, and we plan to further investigate whether these PIMs or adherence induced by the medication assistance program further affect other outcomes, other clinical outcomes such kidney injury or death. Probably we can investigate it with the breast injury too, because it is also an important clinical outcome.
Yeah, thank you for your feedback.
I'll add just one quick thing too. We did use the Atlas incident tool, and we did do some kind of exploration around age groups and Charleston comorbidity scores. So we did some preliminary work on that status of whether they had the PACE insurance or not, but not a full-blown analysis with the comorbidities as a covariate, for example.
Can I add to this? Since you have Atlas, you could use the character. So now people who fit that criteria, so people who, let's call them cases, people who actually been identified as inappropriate PIMs, as belong to PIMs, you can take those cases, those cohorts, and throw them in characterization in Atlas, and it can give you the high-level distribution of all their conditions at baseline. So when you report the incidence and you see that, look, we have that uptake, that occurrence happening in the data source, you can also give a high-level description of what the comorbidities of these people at that time. And you can use Atlas without any, you can use just the standardized characterization, which could give you, what's their level of cardiovascular diseases, levels of diabetes, and all those like high-level standard features, without doing even anything. Like it's a click in Atlas to get that distribution, to give an idea of who are these patients, what were the conditions they were most likely to have. Of course, you're going to see the common 65 plus distribution of comorbidities, but you could see if there's any more insights of like maybe they have some certain features that you were not thinking of.
Yeah. In terms of like Azza said, and also the previous speaker Adam said, there is a plethora of applications for your definitions here. And the applications include not only quantifying the use of these potentially inappropriate medications, but also understanding who are the subtypes of patients who are getting these potentially inappropriate medications, and potentially validating the impact of the use of inappropriate medications. Like, is it falls that go up among those who get potentially inappropriate medications? Maybe because of the falls, they have pressure ulcers. So all of those could potentially be quantified. And I don't know if the American Geriatric Society or BS has validated these drugs to be inappropriate or not by observing in data. Like, is it impacting patients in a negative way empirically, or is it an opinion of people who dispense these drugs? So these are I think there's a long list of applications for your work, and so I welcome this slide because this opens up those applications.
Thank you.
Yeah, thanks. It's really great to learn that Atlas is such a powerful tool, and there's so many things we can continue to do. And yes, and if there's an interest, we would like to incorporate the BS criteria defined by our computational approach with Common Data Model into the OHDSI Phenotype library, so that more people can join to do this interesting and important work. And incorporating this approach into our OHDSI Phenotype library has several potential benefits. As we can see that standardization, the integration will enable consistent PIMS definition across institutions, enhancing the study comparability and align with OHDSI's goal with creating a common language for observational research. Besides, it can increase implementation efficiency, enhance patient safety research, and improve pharmacovigilance. Last but not least, it is beneficial for quality improvement. So to do this, we kindly request guidance on how to proceed and what resources or documentations we should prepare to incorporate this PIM definition into the OHDSI Phenotype library package. Thanks. That's all.
Thank you. First of all, kudos to all the wonderful work that you've done and the clarity in which you have presented this idea. I think you can sense from the excitement in this group already that this is going to bring huge value, not just to the OHDSI community, but to the entire field. In terms of the incorporating these definitions into the OHDSI library, because you built this in Atlas, this would be a very relatively easy process for you. So one is to declare the intent to contribute, which would be an OHDSI forum post, and I can help you with that. And once you have an OHDSI forum post, a simple script that I can provide to you can extract your definitions from your Atlas instance into a local file, something that called as a cohort definition set, which I think you may be familiar with. If not, I can help you with that. And once that is passed on to me, I just pass it into the OHDSI Phenotype Library's secured Atlas instance. And once that goes from your Atlas instance through the script to the OHDSI Phenotype Library's Atlas instance, I push it to the OHDSI Phenotype Library R package in the next release. We may do some QCs, quality checks, to make sure it is right. Maybe there are some constraints in your definitions that can be removed to make it more broadly applicable, like the drug type indicator field, which is usually not populated globally. So we can make those minor changes and incorporate that into the library with the intent of making it more generalizable. So this whole process, I don't think would be onerous. I think less than half a day of collaborative work could get that into the library.
Thank you very much, Henry, for that.
If we maybe have a call to initiate that to help the group, write the forum post, get the JSONs out, and the technical part, and then once you are able to transfer, once you're able to put them in the OHDSI library, Atlas secure instance, maybe we book one of our working group meeting, maybe end of the year or next year, whatever, depending on our agenda, and use our time together in the work group to do I'm not going to call it validation, but quality check of what transferred and how those definitions look. We can create a cohort diagnostic instance for them, and then divide and conquer among the group who can look at those definitions and see what things did not work because it was maybe specific to their instance, and do all of that work. You said there's 7. How many are they? How many definitions?
37 for now.
Okay, 37. So it won't be hard. We can divide and conquer on the quality check of how they transferred to make sure that they're valid across the network. And the other thing that comes to my mind is the documentation. And when we can have specific call, but since they are based on a particular exclusion-inclusion criteria that is published based on the association, the Geriatric American, right? They were based on, so we need to have that linkage for each of the definition. So it would serve as the clinical description of what they're supposed to represent. So, but we can have a call to make sure the documentation is appropriately accumulated and archived, and then do all that process.
Yeah, thanks.
Outstanding. Thank you very much. We look forward to working with you all on this, and we'll be very grateful for it. I think maybe someone had one more question before I have to jump off in a second, but one more question maybe?
Yeah, I guess, really good work here. I guess I'd like to see I'd like to know how we would use these PIM definitions in the phenotype library in our work exactly. What would be the process that you're talking about?
So the question is how do we use that in our work, or what's the use case of?
Yeah. So how would we use it? How would is it just taking each of the drugs and sort of excluding people who shouldn't be in there? Is that the?
Joel, yeah, so Joel, I think this would just be another drug cohort definitions in the OHDSI Phenotype library that could be used as a target, a comparator, an indication, or an outcome. And you can use it in any of those, and you can use it as an incidence rate analysis. You can use it in another how often project. You can use in as a covariate sort of feature in another study. There's so many applications for it. It can also be, once it's in the library, it could be referenced in an OHDSI network study where it is being used to estimate the fall risk among patients with these inappropriate drugs, so on and so forth.
Okay, and that's what each of these. This is so basically these phenotype algorithms are to determine people who are inappropriately on these drugs. That's the whole thing. Okay. Nice.
Exactly. Well, thank you. Unfortunately, I can't stay with you the rest of the call. I got to go on to another one, but we'll be following up with you all. Thank you. And Shaotong, thanks for presenting. Very good job. Thank you all. Bye.
Thank you. Thank you, Dr. Boyce. Okay, just want to see what before we go to the next one. I just have a question. Jackie, are you on the call from VA Cipher?
Yeah.
Do you want to see if you wanted to give an update on the progress that you're making in the integration of the OHDSI Phenotype library into VA Cipher?
Oh yeah, I'm just checking in with our analyst who's working on that today. They just had other priorities, but I will share with you the phenotypes for your review. We're hoping this afternoon so that we can go over them and make sure there's no lingering questions before we sort of showcase this at the conference.
Excellent. Okay.
And we have plans for the next round of definitions, right, to transfer?
I think we have given. I think we have now targeted 25 definitions for transfer from the OHDSI Phenotype library into VA Cipher. That will go into the production environment of VA Cipher, and that will be the part one or step.
We're still on the 25. Sorry, yeah, I thought.
Yeah,
okay,
yeah.
Okay. We're still on then.
And once we do that, and we have successfully put in the VA Cipher, then it will be, integration will be on demand. Like whenever VA Cipher would like a next batch, we can have a next batch extracted.
But look, Jackie, you're gonna have like PIMs now in those that are gonna eventually be in the VA environment, which is awesome.
I thought that was actually a really good one because obviously, as with any health system, there's a lot of geriatrics work. So I think people would be really interested to use that.
Yeah,
so.
and they're also quality indicators.
Yeah.
Those PIMs are also, so it's like it has a lot of use case.
Yeah. Great presentation. Cool. I'll keep you posted, Gavin, this afternoon.
Okay, great. Thank you. Welcome, Shika. Okay, so the next topic on the agenda is to continue our brainstorming on the OHDSI Symposium. So I'm going to share my screen. It's basically the email. Go ahead.
And Dr. McCauley is not here if we have any update on the network study.
We did. So my name is Will. I work with Dr. McCauley and Dr. Martin as part of this study. So as far as the updates to it, Joel has graciously taken the time to help us with a code review, and we think we've identified our problems that was causing non-convergence of the models on some of our partner sites and fixed those. We had one or two last-minute bugs that popped up that prevented us from fully validating that, but we hope to get that resolved very, very quickly and then get data off to our partners. Our goal is to get data back before the OHDSI Symposium. Whether that's overly optimistic or not is yet to be seen, but we're extremely optimistic that we finally have an executable study package that will at least get us results or definitively show that we won't be getting results from these data partners.
That's fantastic. Thank you for the update, Will. And I'm really looking forward to meeting the team and the OHDSI Global Symposium in just 2 weeks or in a week.
Oh, absolutely. And thank you to everyone here who's helped contribute it. And special thank you to Joel for graciously giving us more time than we could have possibly have expected on this.
All right.
Joel is the main support here. We would not have that network study without you, Joel.
Okay, so let's continue our conversation about the global symposium. As I think we have on October 24th, we have from 8 a.m. to 1 p.m. And we talked about the agenda for that meeting. We had brainstormed in details for multiple components. There was one component that we discussed, which was a systematic review of use of LLM-based artificial intelligence to help with phenotyping. And we needed somebody to step up and moderate a 20-minute conversation on that topic. So that was the only agenda item that we don't have. We have a placeholder there. And Shika, I think you may have said you were interested in taking that on. So I wanted to hear from you if that is still the case.
Taking what on? Sorry, just wanted to make sure.
So if you remember in the last meeting, we had talked about the use of generative AI to help inform phenotype definition. So there's a lot of innovation probably going on. Some of them are published in peer-reviewed literature that talk about the use of these Gen AI tools. And we were hoping there was interest in the group to have a discussion on that topic, so that we can decide if we want to tackle this as an OKR for next year.
Okay.
So yeah, simply, we're thinking that if you look at the agenda, the last 60 minutes, because there's a lot of interest in advances in phenotyping using new technologies and Gen AI, and there's some work happening across the community, but there's a lot happening outside the community with Gen AI and phenotyping, and this is a very broad. There's many different applications, but we thought it would be useful to spend maybe 30 minutes or 20 minutes with somebody just summarizing what's the state of the I'm not going to say the art, but like what's happening across the field with the ideas of having Gen AI improving phenotyping or how that applications is happening. And there's multiple things. There's few papers that came out with some usage of Gen AI in phenotyping, and we would like somebody to just go over maybe do a quick literature review of what are the things that have been published, what are the ideas out there, so we can just all together understand what's the advances so far. And we know that there's few or maybe one or two applications already in the community that we can also touch on, but we don't know, we don't necessarily have a good view of what's happening outside the community in terms of methods or tools or softwares or whatever. Just anything where Gen AI has been proposed as a tool to do phenotyping, whether regardless of the exact method or the use case.
Yeah, sure. I can take a look. I actually am attending the phenotype development and evaluation one at the symposium. So yeah, I can take a look. I actually just joined Stanford's Star OMOP team just a month ago. So I'm pretty new to the team, but I know that one of our coworkers is going to present a software demo, I think either in the collaboration showcase. I don't remember where he's going to be doing the demo, but I think he got a poster approved and stuff, and there is some Gen AI element to it. I believe that there's some people can select different languages and look up different clinical topics and be able to kind of map to concepts in I think it links into Atlas, or it was Athena. I don't remember, but so I know that he's going to be doing a demo on something. But I can see, so you're talking about Gen AI in terms of phenotype definition, right? I can take a look and see if I can do whatever I can find But if you already have like certain articles that you know have already highlighted or pinpointed, then yeah, I'm very open to being sent those.
Yeah. And the
I can
intent is just
definitely
to
send
introduce
you.
the topic, Shika, so that we can build consensus about on the interest to tackle it next year.
Yeah, and you
Sure.
don't have to be an expert. Just like facilitate that part of the discussion. Like just give just an intro. I can send you a few articles, but if
Sure.
put 2 or 5, 6 slides to introduce a topic and see what people published about it, and then we can have a discussion.
Okay, sounds good.
Thank you. I'll add you as an agenda item.
Sure thing.
So the agenda that we were thinking about is I'll kick off the call. We'll review our OKRs, how we have done this year. And then there is 20 minutes dedicated to Jamie Weaver, who's going to 20 to 30 minutes, where he's going to talk about his work on integrating measurement errors to study estimates. And I don't see him on the call. And then Joel, you will be taking on a conversation on probabilistic phenotyping, some of your new ideas on this topic, correct?
Yep.
And Jackie, do you need any help for your segment?
No, we were going to do a demo and then have like a brief instructional time, like we talked about. It's for people to test out Cipher themselves.
Perfect. And Will, you and the team, I know Dr. McCauley is unable to come for very good reasons. But you're all set. Do you need anything?
Oh, no, I think we are good. We're good. Both myself and Dr. Martin will be there, and we should be able to cover it. And hopefully we'll have some preliminary data to present, fingers crossed.
Awesome, great.
And
If
if we
not,
don't
we
have
will
to,
at least have an update.
yeah, we talked, yes, I think last week, whenever we discussed the agenda, Dr. McCauley said, if you don't have data, we can talk about lessons learned. Whenever we do a network study, there's always a lot to learn, and it's continued to be the hardest thing to do in OHDSI, the network study, and particularly this one, because P-evaluated as the fact that you guys are using P-evaluated in it as a main component of the network studies, I think is very going to be a lot lessons that we can all learn from. Because not many people did this before. This has been a
very good experience from us as far as actually conducting an initial network study. And I'm, in addition to our eventual paper, I'd like to try and find some way to share some of those lessons learned going on. We'll think further about that as far as how to best write that up as well.
Great. And Naza, do you want to talk about the objective diagnostics?
Yeah, so Gautam and I had made meaningful progress, I would say, in the idea of implementing objective diagnostic to make judgments or decisions of a go no go for a given phenotype in a given data source. And currently, our objective diagnostics rubrics are based primarily on the incidence rate that the phenotype would produce in a given data source. And we have made progress, and but we have not socialized this work outside Gautam, myself, Martine, and Patrick. So we're using the time in the workshop, so in the symposium, to start socializing this work and see how can we, improve it and get feedback from people. So what we're gonna do, and currently, Gautam, you wrote currently the work itself is encoded in a standalone R package, correct? Where you give it cohort IDs and it can generate incidence rate and run the rubrics and produce a table of, or produce a data frame of go no go alerts.
That's the intent, correct? It's not fully baked, yeah.
So by that time we will have a standalone package. We'll see where technically where this lives, and then we'll go through an examples of how it runs and what it produces with the group. We have applied this on the list of designated medical events phenotypes that we have in the library. So we'll have those results. And the way that Gautam and I are thinking is produce the output from the rubric and maybe focus on 5 or 6 examples and then divide the groups, the attendee into different groups. And then give you the phenotype in a cohort diagnostic instance where you as a human can look at the definition, look at those incidence rate, and make a decision if you see any issues, or you would just make a subjective decision on if you see any issues with the phenotype in a given data source. And then you'll complete that information, and then we will reveal what the actually rubric have found. And by that, we're trying to really compare what humans, like a subjective human review of an incidence rate can make compared to what the algorithm is suggesting. And it's a simple experiment where we're really just looking if there's a value. We're trying to answer the hypothesis: was the rubric consistent with what humans could see, and did it add any value? And we're gonna do this on whatever. I think we have now 40 people attending the workshop, so we'll do 5 group like maybe 4 groups, 5 each, and do the experiments. And then we'll also provide an intro of how we're doing this, where this lives, and so forth.
And then Shika, you would take some time and please let me know how much time you need, 10 minutes, 20 minutes, and we'll put that in the agenda. And that'll be part of the next year planning group exercise.
Okay. I'm guessing that sometimes with literature reviews, I feel like there's probably more discussion after a presentation too. So I don't know, whatever you recommend, I can kind of stick to that timeline depending on what other things you need to discuss during that time frame.
Maybe we do 10 minutes review of what's been out there, and then we talk about, and then we spend the rest of the time talking about, is there a good opportunity for us to focus on any of these methods? Do we, yeah.
Sure.
So maybe we do 10 minutes and then 20 minutes discussion, and then that would leave us only 30 minutes to, talk a little bit about next year.
Okay, I can do that. Yeah.
Okay, great. So we got the next step. So we will talk with Dr. Boyce and his team to try to integrate the PIMs work that they have done into the OMOP Common Data Models, into the OHDSI Phenotype library. And then we have discussed the workgroup agenda, and I'm really looking forward to meeting you all in 2 weeks.
Any reactions? Yeah, Gautam, Daria?
Yes, I just wanted to mention that, Shika, if you need any somebody, maybe like me, to help with the review of the articles on AI and the advancements in terms of the phenotyping, I'll be happy to help.
Very down to tech team.
I really want to get engaged and do something useful for the group. So I would love to be part of it. I'm having trouble connecting to the OHDSI teams. So I wonder, how can I find you so I get connected with you directly?
I think if you get the emails from Gautam, I think all of us are listed as
Oh,
recipients.
yeah, that makes sense. All right.
So you can
sounds
find
good.
my name and you can email me.
Yeah.
You may see my name twice, but you can email me at either one of them. I have 2 Stanford emails.
Okay, sounds good. All right.
And if not, you can email me and I'll connect you guys.
Sounds good. Thank you.
Rika, now I'm opening your email doesn't come up on Teams. I don't know why. The contact is empty. Maybe just put your email in the chat. This is
I'm I guess both of my emails are in the list for the work group. It's very weird. We're trying to figure out the thing with my healthcare email. I'm trying to use my healthcare email and like my healthcare account Teams, but it's not allowing me to add the OHDSI teams like formally. So I'm like a guest in this one.
Yeah, that's why.
My
okay.
university email is like fully into the OHDSI teams, but it's not the best version of Teams because our healthcare one is more Microsoft focused. I don't know. We're trying to figure it out, and I joined a few weeks ago, and it's been great. We've been figuring out a lot of access and permission issues.
Okay, got to make sure the two ladies find each other.
Oh, I
but,
was gonna say
you might
I
see
can
my
also
university
help
email on the Teams. Like if you look for Shika, you probably will see like a Shika K at stanford.edu. This one is Escotari at stanfordhealthcare.org.
Okay,
Yeah,
I'll email you at everything I can find.
Yeah, I just was thinking, I was like, I've actually started a lit review on some of these things, so I can pull in some of what I have. So I'm happy to help too.
Oh, perfect.
You know what? I am down to do a Google Slides thing, or we do a Microsoft PowerPoint where it's like just a shared document. If people want to add slides and we want to work on it together, I'm totally down for that. Because I feel like everyone has different articles in mind, right? That they've seen or something. And I feel like, you can do one directional search, but if other people have heard like some one-off things, it's always great to cover everything.
All right, so we have a Stanford, VA, and Daria. Are you affiliated with any big name organization? So we can add that too.
I'm part of Odysseus, which is now EPAM.
There you go.
Oh, well,
cool. There we go.
A very big organization.
Stanford, VA, EPAM, Odysseus collaborating on the ideas for using Gen AI for phenotyping. This is great.
That's awesome.
Amazing.
All right. Have a good day, guys, and we'll see you in 2 weeks.
Thank you so much, everyone.
See you.